the opportunity to come out a few times, and I really appreciate this, especially given the topic, which is going to sound a little esoteric, but hopefully within the next half hour or so you'll realize that this is not what we used to think as a rare disorder, and it's increasingly recognized. And now we have very good tools for diagnosis as well as some treatment modalities. We did leave a handout for you over by where you sign up for the CME, if you'd like, and also a very nice pamphlet from the American Heart Association. So first of all, before proceeding, I just want to state that I do not have any relationships to disclose, but I will be talking about some off-label indications for some medications and some pharmaceuticals, so I just wanted to highlight that. So specifically, cardiac amyloidosis is not the zebra we used to think. This was perceived when many of us were in medical school or through training that we thought this was a very rare disorder. It's certainly a lot more common than we've ever realized. And in order to recognize it and diagnose it, we have to have a high index of suspicion, which is why we're here talking about this. We're doing a lot of community-wide lectures to make sure that people understand that it's quite common, actually. And unfortunately, because of the fact that people don't think about it or recognize it, there are a lot of delays in diagnosis, up to 17 visits to see a practitioner before someone can make a diagnosis, which is often 3 years from the time of presentation. And 3 years is getting very close to the life expectancy of patients with this diagnosis. Now, we do have excellent diagnostic tools, as I'll share with you, and some exciting new therapeutics. Now, why am I, as a cardiologist, involved in this area? Well, we see the end result as it impacts on the heart, and it usually causes a restrictive cardiomyopathy. So a lot of the patients that we might see with heart failure with preserved ejection fraction, before it dilates, before it's very thinned out, may indeed have cardiac amyloidosis, and we see this with a very thickened myocardium. Now, there's a number of subtypes of amyloidosis, and I'm not going to get into too much of this, but there's one major distinction, which is light chain amyloid, or AL amyloid, which is almost certainly associated with a gammopathy and hematologic malignancy, versus TTR amyloidosis, which comes in two varieties, the wild type and the mutant type. And that's really much more obvious and much more prevalent nowadays, and I think that's where a lot of the therapeutics have been noted. Now, this is what's actually happening, is this sort of pale pink material here, which is sort of intertwined with the myocytes. It's actually amyloid that's filling in the space where the cell should actually be. And that's obviously non-contractile, and it's going to cause a lot of problems for the individual. Now, how does this occur? Well, on the left-hand side is the light chain amyloidosis, which is mentioned again, often from plasma cell dyscrasias, but any gammopathy can cause misfolding of the light chains and the formation of this amyloid fibril, which is then deposited in the myocardium. Now, TTR amyloidosis is actually a product of the liver, and the liver produces transthyretin, which is the tetramer, that little four-colored area there, and they may dissociate, and when they dissociate, that's when the problems occur, because they reform as, again, an amyloid fibril, and again causing the same kind of infiltrative process that we see in the myocardium. So both end up causing the same process, but they're therapeutically very different, as well as a lot of the diagnostic tools. So as I mentioned, these are the common forms. AL usually hits people in over 50 years of age. It does not care about what sex you are. It's overall quite rare, but it does involve multi-organ involvement almost always. And the median survival, as you can see, is exceedingly low, 4 to 6 months. So this requires a quick diagnosis and then therapeutic intervention. Now, the wild type and the mutant type are a little bit different. The wild type occurs as we get older, and it used to be called senile amyloidosis. Now, it's very common, about 1 million cases per year, but as you can see, up to 25% of adults over the age of 80 have cardiac amyloidosis. That's a huge prevalence in our population. Now, often they may also present with carpal tunnel, usually bilateral carpal tunnel, but I'd like you to notice that from the time of when it's recognized, there's roughly less than 6-year survival. Now, you're right, if it's 80 years old and 6 years, that's not too bad, but a lot of our octogenarians are living much longer, so this does have ramifications about mortality. Now, the mutant type is due to genetic disparities and mutations that occur in the different groups and the different loci of where this can occur. But here in New Orleans area, the most common is in the African American population. And as you'll see, it's quite common. It's up to 4% of all African Americans have this mutant type. So we've got 4% here, and then we've got a large prevalence of the senile type. This is, again, not an uncommon disorder. Now, how do we recognize this? This is not to be memorized, but just to give you a general idea, ALS, again, stands for the light chains. And as you can see, there's a large variety of other manifestations that you may see. Most notably, neuropathy, autonomic dysfunction, macroglossia, as you'll see, bilateral carpal tunnel syndrome. And there's some very unique aspects of some of these presentations that occur. So, for example, biceps rupture, very unusual problem, is almost always diagnostic of TTR wild-type amyloidosis, very unusual. And all of them cause heart failure with preserved ejection fraction. So first of all, just focusing a little bit on light chain. Again, 12 million cases per year, not that common. It's about 1/10 as common as multiple myeloma. And like all forms of amyloidosis, the symptoms and the presentation is rather vague. Dyspnea on exertion, fatigue, perhaps lower extremity edema, and orthostatic hypotension and other manifestations of autonomic dysfunction is very common. Again, almost half see more than 4 physicians before this is diagnosed. Now, the classic manifestations are periorbital ecchymoses and macroglossia, which you see. I have never seen them. I think it's rather rare. But again, the disease in terms of light chain amyloid is unusual to begin with. Now, when they do have a diagnosis, as you can see, again, as a cardiologist, 75% of these patients have cardiac involvement, even more than the kidney or the neuropathies that develop from that. 99% have immunoglobulin abnormalities, again, usually monoclonal proteins that you see in immunofixation assays, not SPEP and UPEP. We've got to be a little bit more specific than that. And we can see a variety of manifestations, and I'm going to go through these with relation to transthyretin. Now, often, an organ biopsy may not be even required, so we may not need to do a cardiac biopsy. If you've got all of the manifestations of some of the abnormal immunoglobulins and everything else fits, well, the best way to do it is probably with a fat pad aspiration, which we've talked about for decades and generations. Everyone has heard about this. But the clear way to do this is, we want to look at serum light chains and serum and urine immunofixation electrophoresis. Just doing SPEP and UPEP is not enough. Now, if we want to confirm the diagnosis and we have abnormal immunoglobulins, so we think it's a problem, we go ahead and do the classic Congo red stain of that biopsy. We can then make the absolute diagnosis, we can phenotype it, we can genotype it, and we get a lot of information. If the actual biopsy is negative, there are other ways to try to do this, and we can perhaps do cardiac MR to hone the diagnosis in terms of the cardiac involvement. Now, the therapy is very similar irrespective of the type of amyloidosis we're talking about. Usually there's fluid retention and swelling, so diuretics are used. Interestingly, ACEs and ARBs are very poorly tolerated in this disease, and actually beta blockers and even calcium channel blockers are also relatively contraindicated. So this is different than when we treat regular heart failure. It's also got a lot of cautions if someone has hypertension and you're looking to treat this. Digoxin is absolutely contraindicated because of the way it binds and can cause significant toxicity. The definitive therapy, though, and I'm not a hematologist, there are a variety of just chemotherapeutic regimes that are used to treat this. It's very high dose, and it may be followed by stem cell transplantation. So that's the overall picture for light chain, which again is unusual, usually deferred to hematologists, and again is an unusual presentation. But what is not unusual is the transthyretin. And this is from a study that looked at a large survey of patients. This reflects the United States population. This is the whole world. And this large area here in blue represents the wild type. And then here we have a specific mutation, which is a big hunk of this. So overall, what we see in the US is an older male African-American population. That's the group that's probably at the greatest risk. And the most common subtype, again, is ATTR wild type in an older population. There is a very common mutation which is vanillin 122 isoleucine, which again is actually seen almost exclusively in African Americans. Almost all the people that have that are of African American descent. Now, let's just look at the mutant form with the genetic abnormalities. Again, 0.3 patients per million doesn't sound like a lot, but that's over 5 million cases here in the United States. And again, this is the major emphasis here on this particular mutation, which almost always affects the heart as well as causes a polyneuropathy. It occurs at younger ages, usually at age 50 or less. So we have to have a higher index of suspicion. If you have someone with heart failure with preserved ejection fraction, and you really can't explain it, they're not hypertensive, and a lot of things don't fit, they're African American, it's a pretty good likelihood that they may have this disorder. We do see it in other areas also. With aortic stenosis, a number of autopsy series have now shown in patients undergoing TAVRs that up to 16% of these patients have cardiac amyloidosis. And then the traditional run-of-the-mill heart failure with preserved ejection fraction, lo and behold, when you start looking for it, which is what we've been doing a lot lately, we see that a pretty high percentage of these patients do indeed have cardiac amyloidosis. Now, the problem is the delay in diagnosis, and this shows you the duration of how long you've had transthyretin amyloidosis, and there's infiltration that's occurring very early on, and as you can see through time, it starts to impact on the New York Heart Association class. The ejection fraction doesn't change until towards the very, very end, but there's a lot of things that you can look at. You might see a little bit of smoldering of cardiac troponins, perhaps NT-proBNP. They're often admitted with heart failure symptoms, and again, the key is to have a high index of suspicion and look for other things that might be causing it. So what are we looking at in terms of the manifestations of this disorder? Well, there's cardiac clues. First of all, intolerance to blood pressure or heart failure medicines. As I mentioned with the other form, the light chain amyloid, things like beta blockers, ACE inhibitors, ARBs, and calcium channel blockers, which is pretty much all the drugs I know, really are not tolerated very well with this disorder. Again, troponin may be elevated. Very importantly, if there's a family history of unexplained cardiomyopathy and as a person at risk, it should be considered. Unexplained thickening of the various chambers on an echocardiogram. Is it explainable just through LVH? Perhaps not. And then you may see very low voltage, but very thick walls. And that shouldn't be. In fact, thick walls in the myocardium, there should be a lot of electricity, there should be a lot of impulse, and the EKG should show high voltage. When it's low voltage, that should be suspicious for amyloidosis. But there's also other things non-cardiac, autonomic dysfunction, polyneuropathies, carpal tunnel, which is classically bilateral, lumbar stenosis, I mentioned the bicep tendon rupture, which is unusual, and then again, a family history of polyneuropathy. So if you think about these things and you think, man, maybe this person could have it, again, you need to take the next step. If we delay, and it's usually thought maybe it's hypertensive heart disease, people maybe get inappropriate care and then again, delays in initiating real therapeutic options here. Now, we have a lot of ways to do this, and I'm a cardiac imager, so obviously this is a disorder that I'm very comfortable with and feel very good about, because imaging really plays a role in this kind of setting where we don't really have a test that says you have cardiac amyloid. There's not one thing. So we have to put this all together, and imaging fills that. But perhaps the best way we used to think about was to make a definitive diagnosis was to do an endomyocardial biopsy. But that has some risk, and it actually is not as accurate as we used to think. So I think imaging has now replaced even cardiac biopsies in terms of making this diagnosis. So let me just run through a few things with you just to show you that the patterns here are very, very different. So these are echocardiograms. First, we may see a pericardial effusion here. We see this markedly thickened left ventricle here. But notably here, the left and right atrium are very dilated. And that's unusual to see biatrial enlargement in the absence of something like valvular abnormalities. We can see RV thickening. And then classically, and the thing that we look for on an echo nowadays, is what's called apical sparing, or a cherry on top for global longitudinal strain. It has this very interesting pattern of how the contractile function of the various regions of the myocardium. And this disease spares the apex, and it's one of the only ones that does. So when you see that little sort of target like that with that cherry on top, we start to think that echo is now starting to give us a clue that this might be cardiac amyloidosis. So I've gone through most of these, but those are the key aspects. And from a cardiology perspective, all we have to do is have a high index of suspicion. We start to see these things, and then the red flag comes out. Now, cardiac MR is even a more refined test. It's not very specific, but it starts to increase our suspicion. We see increased LV mass, we can see asymmetric septal hypertrophy, and then we see scar tissue, which is detected by late gadolinium enhancement, which is a tracer that's used and can show us non-coronary scarring. So instead of having like a prior MI with a clear area of vascular distribution from the late gadolinium enhancement, it's a very patchy looking thing. And you can also see it in the right ventricle. So there's a number of different ways, and then we get down to some more refined ideas of looking at extracellular volume with a specific approach with T1 mapping. And that might be the earliest manifestation. But again, a lot of processes can sort of resemble amyloid, and it doesn't necessarily tell if it's light chain or transthyretin amyloidosis. These are some of the patterns that you see. This is essentially diffuse uptake of the myocardium here. Here we see a little patchiness of the late gadolinium enhancement. Here it's almost circumferential. Now this would be a normal patient, dark myocardium, white blood. When we get the situation where we can't even see the myocardium, it's called abnormal nulling on a magnetic resonance study. And that is demonstrative of this abnormal amyloid infiltration. And it's pretty pathognomonic for the disease process. So we see a lot of value here in doing MR studies. As you can see from this slide, very high sensitivity and specificity. We can look at various things. And it also may have prognostic importance in delineating which patients are going to do poorly and which ones might be having a better prognosis. But I really want to highlight this because this is something you can do at East Jefferson, we can do at Tulane, you can do it everywhere. It's an old-fashioned test, and we're going to talk about technetium pyrophosphate, which is a bone imaging agent, which was used for the detection of myocardial infarction about 30 or 40 years ago. And it sort of was put on the shelf, and all of a sudden people noticed that in this weird process of amyloidosis, it is abnormal. And you can see here in this image, you see in this transverse section, you can see this yellow area, which is the left ventricle. And it's taking up this agent. And this agent shouldn't be there except in bone, as you see here in the spine or the sternum. So what's going on here? Well, we don't really understand the process, but clearly this is something really, really pathognomonic for it. It's very easy to do. It's inexpensive. It's a short protocol. And again, these are some of the rates of diagnostic accuracy we're seeing. Sensitivity, I think 97% is a little overstated, but perhaps 90%. And I think when the immunoglobulins are negative, the specificity is close to 100%. So we've got a really good diagnostic tool. Now, interestingly, this is a diagnostic tool for transthyretin amyloidosis. So it doesn't really help us too much with the light chain, although it can still be abnormal in light chain cardiac amyloid. So this just shows you how fast we can do it. No fasting is required to give the dose. You take some images an hour later, and you're pretty much done with most of the patients. And then we can look at this. This is what a normal person, hopefully all of us, looks like. There's bony uptake into the sternum and the ribs. Here we see a little bit of a cardiac silhouette, a little bit more, and now we see a lot of activity. And the more activity you see, the more diagnostic it is, and you can make a conclusion. We can actually also do quantitation of this just by doing regions of interest around those areas. And one is we make the diagnosis, and we also know when there's a lot of activity here versus the contralateral alone, that's a poor prognostic marker. Again, identifying a patient that may need therapy, and as we talk about therapy, we want to be sure of the diagnosis because the treatments are very expensive. Okay, just to highlight this is an early slide going back almost 7-8 years ago, where we used to think that the cutoffs using this pyrophosphate scan was very good at delineating whether it be TTR or transthyretin versus AL, but we've learned that that's not really true, and there's some overlap, and up to 1/3 of the patients with light chain amyloid actually can have pyrophosphate activity. So it doesn't exclude that, so we need a little bit more of an advanced algorithm to try to hone this. Now, again, I think it's really important not just to make the diagnosis, but also to look at the prognosis. So patients that have a clearly abnormal ratio and have a lot of activity noted in the heart regions as opposed to the contralateral alone, overall do very poorly. And as you can see here, at 3 years, there's only a 40% survival. So not very good. If you don't have the uptake, you do much, much better, or if it's a little bit, you do much better. So there's a variety of different tests that I've tried to outline that helps us with the diagnosis. I think echocardiography is the first line to start to look for things. We start to see abnormalities, but it is not going to give us a diagnosis. The cardiac MR is good, but again, it's only suggestive. There's other processes that occur. So I think the initial diagnostic approach is using pyrophosphate scanning and also doing some of those laboratory tests for looking at immunoglobulins. And then if we can't still make a diagnosis, a biopsy might be indicated, but I think nowadays it's pretty unusual to do that. So this is sort of the take-home slide. It's very busy, but for the most part, if someone presents with heart failure, syncope, bradycardia, and has an abnormal echo, and you start to think about that this diagnosis could occur, the next step is likely doing bone scintigraphy with pyrophosphate. If it's completely negative and the light chains are negative, then we don't have any evidence of cardiac amyloidosis. If there's very high activity in that area and the light chains are negative, meaning there's no AL or light chain amyloidosis, then we've confirmed transthyretin and we can get on to the spectrum of how we treat that. And then we have some areas in the middle that might require a biopsy or not, but I think this is the starting point. So the two key areas are bone scintigraphy and then serum and urine immunofixation with serum-free light chains. And if you do that, and the immunoglobulin studies and the monoclonal assessment is negative, then it can only be TTR. Biopsies, again, we do very infrequently. I think across the world now that doing endocardial biopsies for this diagnosis is not really necessary. There may be certain areas where we have equivocal findings where a cardiac biopsy looking specifically at myocardial tissue would be helpful, but most of the time the answer is no. We don't need to do it. And we have a lot easier to do. Just draw some blood, do a scan, and we're finished. Now, what do we do to treat this? This is very challenging. So this is where I think we've learned a lot. Now that we're making the diagnosis far more common, we've learned that we have to start to alter how we treat what used to be thought of as heart failure with preserved ejection fraction. Standard stuff, diuretics and salt restriction. Again, calcium channel blockers and digoxin are contraindicated. They will make people worse. It's something to avoid. And then we have to really be careful, even using the other medications like ACEs, ARBs, and beta blockers, because patients may not tolerate this due to autonomic dysfunction. They may have